Welcome to Johns Hopkins Medicine online webinar series. Today, Johns Hopkins plastic surgeon Dr. Christian Broderick will be speaking on breast reconstruction revisions, restoring form and function after breast cancer reconstructive surgery. Before we get started, we'd like to provide some user tips so that you are comfortable using this platform. The first 30 minutes of our program will include an informative presentation by our presenter. The last 30 minutes will be dedicated to our live Q&A session. To submit a question, please type your question into the Q&A box and click send. Your questions will be seen by others watching this presentation, so please note if you do not want your name attached to your question, please check send anonymously. We will do our best to answer all questions we receive during the Q&A session. Alternatively, you can email us questions and feedback to hopkinsseminars@jhmi.edu. Please note this program is being recorded. At the end of the webinar, we would greatly appreciate receiving your feedback and ask that you complete our survey. A pop-up window will appear at the end of our program for you to complete the survey. And now I would like to welcome Dr. Christian Broderick to begin our presentation.
Good afternoon, or evening, I guess it is. My name is Kristen Broderick. I'd like to thank you all for joining us this evening, and we're going to do a little bit of talking about revisions of breast reconstruction, which I think is a topic that doesn't get discussed very much. There's a lot on the internet about what reconstruction entails, but what do you do once you've been reconstructed if you're having some issues with your shape or function, and what we can do about it. These are my disclosures, none of which are particularly relevant today. So I'm going to talk a little bit about ways to improve the form or the shape, and then also some functional aspects of reconstruction, because we're talking about the entire body. I will show you some of my more extreme cases. Most of my cases aren't like this, but it sort of shows some of the thought that goes into how do we get reconstruction accomplished in some women. And then a little bit about the future of breast reconstruction, where we're headed. So, many of you know that due to innovations in breast reconstruction, we have taken a large step from more than just implant-based and autologous or a pedicled flap-based surgery that we were doing about 30, 40 years ago. We're able to do free flaps, things like the DEEP flap, the S-gap, all those other alphabet soups that you may hear about. We've had advances in fat transfer where we're able to do lipofilling of the breast, taking fat from one part of the body and moving it to another part. We've had a lot of innovation in soft tissue support to help support the skin of the breast with various types of meshes. And the breast surgeons have been able to improve their techniques and candidates for nipple-sparing mastectomy, so we're able to spare that part of the skin of the breast. We also combine some oncoplastic techniques in lumpectomies with breast lifts or breast reductions at the same time. And we have better understanding now of how we time all of our additional adjuvant therapy around reconstruction. Some more modern alternatives that we've gotten better at are direct to implant, where it all happens at a single stage. Something called a Goldilocks procedure, where we utilize any redundant skin that's left at the time of the mastectomy, and we form a breast mound out of it that doesn't really require any additional treatment. Some patients are going flat, and we're very, very pleased to provide that as an alternative, and I'm very happy that that body positive movement has gone so strong. And then we're getting better at our methods for using all lipofilling to reconstruct the breast. That usually takes several rounds. You can't usually do it with one time. So when I was early in my practice, what I really imagined that revisions would look like would be, somebody who had implant-based reconstruction, whose nipple was a little bit malpositioned, and I would do a simple mastopexy and get them revised. And that's really kind of where I thought we were predominantly going to be headed. This is a patient who has what we call an animation deformity. So she has her implants in under the muscle. Many of you in the audience may have something similar. You may have seen this. And the problem is that you can move the breast skin. It can be very discomforting for patients. So I started seeing a lot of patients who had problems with submuscular implants. Animation deformity is one of them that can cause pain. Some people have decreases in their strength and problems with mobility. Also muscle spasms. The radiation has a pretty strong effect on the pectoralis muscle. So if the patients are radiated, we really see a lot of that thickening. And then the implant over time can become malpositioned, and you get window shading of the skin above the implant. And a lot of that has to do with the technical ways that we use to do breast reconstruction. This is the way I was trained. This is a very solid, safe reconstruction, but it does sometimes cause these problems. And it's because traditionally the implant was placed underneath the pectoralis muscle. So the schematic here on the one side shows the implant underneath the muscle with a sling mesh material to reinforce the lower pole of the breast because the muscle doesn't go all the way down. Sometimes people use the fascia or the lining on top of the serratus muscle. But the advent of and the use of surgical meshes has actually helped us a lot in innovating and changing how we do reconstruction. And now we've gotten pretty good at doing what we call the pre-pectoral technique, where you go above the pectoralis muscle and you don't have to lift the muscle up, which has given us some advantages. So like this patient, for example, who is no longer going to need to have her animation deformity. The postoperative care, in order to achieve the right shape of breast in the subpectoral plane, causes some of these changes that we see later on. Number one, the expansion has to be very slow because it's very painful to expand that muscle. We used to overfill all of our reconstructions with our expanders, knowing that we were going to lose some of that pocket space, and our final reconstruction needed to be a little bit bigger. And what it would do over time is force the lower pole or the bottom part of the breast and the front of the breast to expand. So we got that nice natural pout of the breast, if you will. And then at the second stage, for those of you who had two-stage reconstruction, we had to do a lot of repositioning of the inframammary fold because that forced expansion really stressed those borders of the breast where there wasn't as strong a tissue. So we were reinforcing the fold of the breast, the side of the breast, and then releasing a lot on the upper and the roundness in order to get that kind of a look. And we got pretty good at that. So we've shifted a lot, though, to now that we have other techniques that have helped us do this pre-pectoral. So this is a schematic, and there's a lot of different ways to do this. But basically what we do is we used soft tissue support, usually with an acellular dermal matrix. There's a lot of other meshes that people use to help establish the folds of the breast, both on the inferior portion of the breast, but also laterally on the side of the breast to keep the breast from the implant from migrating underneath the armpit. But what we also found is because we are on top of the muscle, we don't have that muscle coverage anymore, which helps camouflage the top of the device. So we use lipofilling or fat grafting or fat transfer to thicken the mastectomy skin envelope in order to camouflage the device, which we had been doing for subpectoral reconstruction for a long time as well. But what we've discovered is that it's not just not subpectoral. When you do reconstruction above the muscle, you actually get some shortening of the lower pole of the breast, or basically from the nipple, the skin from the nipple down to the inframammary fold. And you get atrophy of the subcutaneous tissue. So that skin is not as thick. The fatty layer underneath the skin atrophies with time due to scar tissue. In very thin patients, that can be a problem because it's very hard to fat graft into very thin scar tissue. You have to wait a little bit longer for the capsule to form because the capsule is not as strong on top of the muscle as it is below the muscle. And basically the entire reconstruction relies on the strength of the acellular dermal matrix or whatever the mesh is and the skin itself. So this is a schematic, and you can see on the one side what it looks like if you just lipofill the upper pole. And while that will help with your overall shape and turn it from sort of more of a grapefruit round implant into an upside down ice cream cone, if you lipofill the entire skin envelope, you can actually get more fat into this area because the fat will survive better, and you can go smaller with device. So we have sort of perfected that technique and described it. And this is sort of a schematic of one of the papers we published looking at this, where if you take fat and you distribute it throughout the entire breast skin envelope, you can actually get much more fat. So the patient's own tissue is actually part of the reconstruction. It's softer, it camouflages the device. And for the most part, we can get away with just one round of fat grafting. And very thin patients, you have to do more. So why do we do this? Number one, we have to restore that fat, or the skin is basically draped over the device and you can see rippling and other problems. And we have found that if you use more fat in a smaller implant, you can get the same overall breast size in order to camouflage the rippling. It appears more natural, and we think that there's less wear and tear over the skin due to the weight of the device, but maybe I'll give this webinar in 10 years and I'll change my mind. Where do I take fat from? I like to get my fat from I tell my patients I can get fat from anywhere on anyone, no matter what your BMI is. I just have to be a little bit more selective. I do provide the thighs and the upper abdomen. I prefer to save the lower belly because we do see patients when they get recurrences and they need radiation, and I do like to preserve that belly fat for a deep flap if they need that later. Everybody wants me to suck their flanks, but unfortunately it's very stringy. There's a lot of fibrous tissue in there, so it doesn't make good fat to transfer. And fat, I think, has memory. So if we take it from an area where you tend to gain fat or lose fat, it'll remember that when we move it up to your breast. So this is an example of a patient that I took care of, and you can see she has some of the stigmata of a pre-pectoral reconstruction, in that she's got a lot of rippling, and these are the marks that I used of how I sort of fill it, and this is what it looks like intraoperatively, where we've actually placed the fat in over the sizer device, and we're able to really thicken that skin. One other thing that's helped us is that we now have more cohesive implants. So silicone implants used to be very sort of molten, if you will. If you cut into them, they would sort of leak out like molten jello. But we now have cross-linking of the devices of the silicone within the device. And so it's what we call a more cohesive. You guys may have heard this term, gummy bear implant. I think that's a bit of a marketing technique, but what it does is it means that the implant holds its shape when it's subject to gravity. And that's really helpful in smaller implants. You see less rippling, and so you don't have to do as much lipofilling. The downside is in larger devices, so if you get out to the heavier implants, the 700, 800 cc devices, that cross-linking makes the implant very firm. And when you sleep at nighttime, the pressure on the implant, it doesn't really deform. And so it actually ends up flipping. And then you have the implant face the wrong way in the chest, and it doesn't look like a natural breast. So we go lower on our cohesivity. I wanted to give a little shout out on implant monitoring. The FDA revised a lot of their recommendations back in 2020, and we have some updated information on that. But for now, all silicone implants should be imaged if you get them for augmentation or for reconstruction with an MRI at 5 years, just to make sure that the shell of the implant is okay, and then every 2 to 3 years following that. For monitoring for the very rare lymphoma called ALCL, that was predominantly associated with textured devices, which have been taken off the market. There is no unusual monitoring. So we monitor like any other device. But if you do notice an enlargement or a late seroma of one breast, then we do get a little bit more interested. That's the most common presentation. So you'd want to see your board certified plastic surgeon to have that worked up. I'm going to shift gears a little bit now and talk on some of the newer techniques that we've got that has helped us with some of our reconstruction revisions. So this patient, you can see instead of having the traditional scar when the nipples need to be removed, traditionally we would, in a larger breast that's more ptotic, we would make a scar across the front of the breast in a straight line. And the problem with that is then it flattens out the front of the breast, and it just wasn't very pretty. And when you do an autologous or deep flap reconstruction, then you end up with this oval shaped skin paddle that when you put an nipple reconstruction on it, it ends up looking like an eyeball. But we've been able to utilize the same techniques that we do for breast reconstruction or breast lifts in how we close the skin now. We've gotten much better with this. We can support the lower part of the breast with the skin from the lower breast skin by removing the top layer and folding it under. So this patient, we did this on, and you can see, even though she lost one of her expanders due to an infection, when we finally got her reconstructed, you can see these are deep flaps I did on her, and that's her nipple reconstruction with a tattoo. But because we were thoughtful about how we shaped her skin in the beginning, we ended up giving her something that looks, very much like she had a breast lift or a reduction. So let's talk about some revisions. I've got a couple complicated patients. This was one of the first pocket transpositions I did, and she had submuscular implants, and you can see she has the stigmata of somebody who has had just decades of that muscle, because when you put them under the muscle, that muscle still fires. So it's constantly pulling up. It's pulling on the skin. And what it ends up doing is flattening the top of the breast, and the implant gets pushed down and out to the side, and the skin gets distorted in the process. So you can sort of see that. She was having a lot of pain, a lot of animation deformity, did not feel sexy in her breasts. She didn't have a great abdomen for a deep, and she was a smoker. Plus, she lived far away, so I wanted to make sure I could keep her close with something safe. So I started out actually by thickening her skin first to make it a little bit more favorable for what we call pocket transposition, where I put the muscle back down on the chest wall and then redo the reconstruction on top of the muscle itself so that we can use that skin envelope. So this is before we did the pocket exchange, where I just did some liposuction, transferred that up to the top to help thicken that skin and make it much more amenable to getting her pocket transposition. She went home, she lost some weight for me, and she also stopped smoking. And so we were able to transition her to above the muscle. Now you can see these are temporary, but I put these little yellow bolsters and sort of tent to hold the acellular dermal matrix in place. And that's what actually holds the weight of the implant in place, but it's all the rest of her skin. You can see I didn't do anything to change her skin. It just went back to her natural skin envelope that she had at the time of her mastectomy. So you can see her before and afters, and we were able to really improve her look. So other people who have failed implant reconstruction are good candidates for some type of revision down the road. It's either due to the very thin skin flaps, radiation changes, which really can ruin the skin. We do see that it affects the muscle a whole lot more than the skin. Other people have had prior surgery and scars in areas that make it a challenge to do this kind of reconstruction. If you get an infection and lose your device, or if you get capsular contracture, or heaven forbid, you get buttonholes at the time of surgery. I think these are challenging both for the surgeon and for the patient. Patients come in with high expectations. They're thinking about aesthetics, which is their right, and I applaud that. But previous traumatic experiences can really color your ability to have some optimism moving forward. It's really important to build trust with your surgeon, particularly if you switch surgeons, and just be prepared that you may need to plan several stages. So these are the typical places that we take your own tissue from if you have to do that. I always think we have tools in our toolbox, the most common hammer being the DIEP flap. And this is a patient who had implants and she wasn't happy with them because she kept getting recurrent infections. So we did a DIEP flap on her, and that's not novel. We do like doing DIEP flaps. This is me with one of my chief residents doing a flap surgery. This is a similar patient who had implants in place and just wasn't happy with the feeling of having something foreign in her. She also had some animation deformity, and so we did her flap surgery, and she was very, very happy. She also used this as an opportunity to get healthier, lost some weight, and we took advantage of that with her skin. But what if that's not an option? Many surgeons now, DIEP flaps are sort of uh, uh, have become a lot more common. Many centers do them. But some patients show up in my office that look like this. She's already had a DIEP flap and she's very unhappy with her asymmetry. She also had radiation. So the challenge for her is I don't have that as my best donor site. So she had had a modified radical mastectomy. She had lost her implant after an infection and lost all of that skin, had radiation. She had reduction already on the other side, and she had an implant in actually underneath this flap, but she didn't want to just reduce the left side. So this was my first year of practice, and I'll tell you, this was a challenge for me, as it would be probably for many plastic surgeons. So she was lacking a lot of things. She was lacking skin and volume. She had a pretty impressive disproportionate to the folds of her breast. It made it really hard to get a bra on. Even a prosthesis, that didn't really help her because the bra didn't sit at the right level and her one breast kept falling out. And she had a lot of tethering at the upper inner part of the breast, which I consider kind of the social part of the breast that people see. I asked her, why can't I reduce the left side? She didn't let me do it. So we started first by improving the quality of her skin and seeing what I could do with fat grafting, which I think helped us actually down the road. If you look at her before her second stage, she's gotten a lot of relaxation in that upper inner pole. And we were able to do a lot with that by preparing the skin. I ended up using some skin and fat from her back. She really didn't have options for a free flap because both of her vessels had already been used. And when I got in there, she had this tiny 100 cc implant, which I think in her was undersized. So we upsized her. We brought in some skin I really did like the shape of the lower part of the breast. And so we brought the skin in from above. And after multiple surgeries and actually several years to let the skin rebound, we finally got enough volume, and she finally let me at least do a lift on the other side. And so here's her result before her nipple reconstruction. We did a little bit more revision on that. So if you look at her from before to end, is this my best result? 100% no. But we finally got her to something that was very stable, she could get into a bra. She felt confident in her body, and she's been very happy with that. I have another patient who had failed breast conservation. She showed up in my office and said, I have pain and I have no breast. She'd had a prior lumpectomy and radiation on the right side, but then the left side was completely flat. And it was very confusing to me because her cancer was on the right side. So I was trying to figure out what happened to her left side. And her last surgery had been 5 years before, and she had not been back to a plastic surgeon. So I said, something's not adding up. So I did a deeper dive and we had long conversations. We had multiple visits to get her there. Turns out she had a breast augmentation 12 years before, then had a mastopexy or breast lift, then got her right breast cancer with lumpectomy and radiation. And she was uneven. So the thought at the time was to do a revision augmentation mastopexy breast lift. She developed capsular contracture on the right side, so they pulled that one out and took both implants out. And at that time, she lost the nipple on the left side. She had to have a wound vac debridement. She had draining sinus tract. She had all of this trouble. And I think that this was compounded by the fact that she'd had prior trauma due to a head and neck cancer where she'd had lots of excisions. And she said, I just can't handle a free flap, Dr. Broderick. And I said, okay, even though that would have been a great option for her. So, on her, looking at all of her problems, I just decided we just needed to start over. None of this tissue was healthy. It was all necrotic fat. She was missing so much skin. So I looked at sites for her. She had, you can see she's got a scar on her lower belly where she had a mini tummy tuck, so that was out. She didn't have great thighs for a thigh flap for me, but she did have good skin and muscle from the back. So I went with a very traditional, which works really well, surgery for her. But before we did any of this, we had to sort of address a lot of these issues with her. She'd had loss of trust and body image concerns. So before I got her to this stage, she spent a lot of time working through with a therapist, how she was going to handle the ups and downs of repeat surgery. Because, you know, this is something that is, we can get a result, but if we haven't healed the whole person, I feel like we haven't helped people. And she is now actually one of my biggest advocates, and she'll contact patients to discuss her journey and encourage mental health care because I think it was helpful for her to have a better toolbox at the time of her reconstruction that she could draw on when she had any issues, problems with wounds. And so we're still working through her care. So if you're going to undergo any sort of revision, I always tell patients that the shortest way there isn't always going to be straight. We may have to go through multiple operations to get there. We always analyze the deficit and we break it down into the various components and we address them one by one. Um, you know, we are, as surgeons, we're very sensitive to the traumatic aspect of patient surgical history. So you have to let us know what's in your head. And I think it's really important to find a board certified plastic surgeon that you trust. The relationship is really important. So these are our surgeons. I'm part of a really big team. There's 6 of us that do all of this. And I'd like to touch a little bit on the importance of research, particularly in what aspects of this that refer to breast quality of life. We have a campaign going right now at Hopkins about how research saves lives. And I always tell patients when I'm talking to them about reconstruction that there's no medical reason that you need to have a breast. A breast doesn't help you with anything except for your mental health and your sense of body image and the sense of feeling whole, which is why we do it, right? And so we have lots and lots and lots of research that supports that. We have, looked at breast quality of life and what aspects of what we do matter to try to help hone in on this so we can answer the questions that are the most important for patients and to be able to be advocates for our patients on the Hill and really address their needs. I want to touch a little bit on older patients because we are now an aging generation, people who used to be considered too old for reconstruction. We're kind of realizing that that's not true. And I think that we had been doing a disservice to people by not offering them reconstruction. We're focusing more now on this concept of frailty and not so much age. And frailty brings in not only a chronologic age, but what are people's physiologic age? Do they have high blood pressure, diabetes, heart disease, a bunch of other things that make them more into the frail category? Or are they, going to the gym every weekend and doing kettlebells and are stronger than I am, in which case the age is sort of just really just a number. And we've partnered actually with our geriatric department, and there's a lot of other surgical subspecialties, orthopedics, general surgery, GYN that have looked into this as well. And we've actually found that looking at frailty as opposed to just looking at age is actually a better predictor of who does well. And partnering with our geriatricians to help patients identify what's important to them when they head into surgery um, uh, will help get them through that. We found that if we do what's called prehabilitation, or getting people ready with some prehab as opposed to rehab, we can actually benefit them a lot. We do a lot of pelvic floor therapy, which helps strengthen the floor. I talked about geriatrics, and then postoperative care, I think, needs to be tailored a little bit differently. We do tend to have slightly higher complication rates, but as long as we know that going into it, we can anticipate that. And when I do my deep flaps on my older patients, I always placate their rectus muscles because I think it helps with core stability. We've looked at, things that are important to all patients after they get deep flaps or using their own tissue, and looked at what's important about the abdominal well-being, and actually working with this population has helped us translate a lot of these things to all patients. Obviously, not everybody needs a geriatrics consult, but I think it's important to think about the shape and the outcome of the abdomen when you're doing autologous reconstruction. I know I slipped a little bit from implants to autologous, but deep flaps used to be, he had the mark of this very high straight scar with big dog ears, and this big belly button. And I think that we've done a lot of work to help enforce the aesthetics of this. That's very, very important for people to feel whole afterwards, and I think that's really important. Lastly, I'm going to touch a little bit about meeting some of our diversity needs. We realized in some of the research that we've done is that we have not done a good job in providing adequate online resources for patients. So I have a student that was this was sort of her project for her research year, where she looked at the fact that there is this sense of body self and body image that really gets damaged. It's not just a breast. There's a lot more to it. So 1 in 8 women develop cancer. You guys know this. 35% require a mastectomy, and a large majority have some sort of body image distress. Everybody knows, maybe don't know, that 100% of breast reconstruction should be covered by insurance. It's the only surgery that has a federal law mandating that insurance companies cover it under current guidelines. We have also looked at who gets reconstruction, and while we're still getting better reconstruction over time, we're lagging. The top line here is, white women, and the other ethnic groups represented still lag in terms of getting reconstruction. Some of this is access, some of this is shared decision making. So we did a pilot study where we looked at, talked to patients and got their opinions. And we really wanted to say, what does the patient think? And we did a lot of quality type research where we had long interviews with patients, and we took some of these information and we sort of brought it together. Many of them just experienced some decisional regret. They really felt like that they should have been more familiar with the quality of the reconstructive outcomes that could be expected, and wanted to see some results. Like, everybody wants to see results. So these are our options that we talk about with patients, but what does that really look like? What does it look like in the middle? Readability has been well described, so we feel like we do a good job in terms of educational literature, but visual content is very, very sad. So we did a Google search, which isn't very fancy research, but it helps us understand what most people find, where we looked at breast reconstruction and took images, and we really specifically were just looking for the images in the top 10 websites. Plasticsurgery.org is the American Society for Plastic Surgeons website. And this had on it the vast majority of the before and after photos where you could see what people look like. But what we didn't have, the majority of it was stock images. So, and these were predominantly white skin tones, whereas the rest of the population distribution is not predominantly white to that level. And it was also a bunch of slender body images. Most patients getting reconstruction are older, and they may not have slender frames anymore. Time, age, and gravity affects all of us. and it's specifically in the overweight and obese population. They tend to have poor postoperative satisfaction and increased risk of complications and low self-esteem and body image afterwards. And I think some of this may be exacerbated by the lack of representation in these visual aids. So we have done a lot of work and actually put together something to help with this lack of patient representation, and also to help set more realistic expectations. So she has taken photographs of some of my patients, and granted, this is a white patient, but she's more on the round side, and she's done artistic renditions of all of the various stages so that people can see what rippling looks like, what do nipples look like right after they're done, what do tattoos look like, what does it look like down the way. And we've put together a visual guide that I think has been very helpful for people, which shows lots of different stages and what people are looking for. Another thing that we've done to help increase the voice of patients is a storytelling project, which was sponsored by the Plastic Surgery Foundation and Hopkins with one of my partners. And we've put together patient stories. So all of these patients were taught, they were volunteer, but they were taught in the art of master storytelling, and they have told their stories, and these are available on our website. And I have one that you can listen to, but I think it's helpful for people to hear from other patients going through this, what their experience was. And I'll play just a portion of this video for her.
I don't come from boob. True story. Family who, after breastfeeding, no longer needed a bra. They already had small boobs anyway, but they shrunk after that process. So for me personally, when I ended up at 18, more than 20 years ago, in a size medium bra, I felt like I was winning for my genetics. It meant that it made a difference in my clothing, but it also meant that I could still game the system by getting t-shirts in the girls section, which I still do. So when I ended up with extensive stage 0 breast cancer, which meant I needed to get a mastectomy, all I wanted to do was keep what I knew I was going to lose. And I still remember the first surgeon I consulted with. Now, I had to consult with multiple surgeons because my stage 0 was so extensive. My first doctors thought it might be more. So I went to multiple hospitals, which also meant multiple breast surgeons. The first one I had was a male, and he was the only male I had, so he was especially memorable for that reason. And I still remember he was able to tell me what my breast size was down to the quarter cup without even a tape measure, which was impressive, but also freaked me out a little bit. And his assessment of me was, "You're small." And then he asked me if I wanted augmentation, but being committed to my medium boob life, I said no. And he looked at me as if he was some sort of boob Picasso. And by me not requesting double Ds, I was preventing him from doing his best work. But again, committed to my medium boob life, I did not waver. And that was not the last time I heard that. I also heard that at other hospitals. I got some variation of, "Are we going bigger?" And again, being committed to my medium boob life, I said no. And I even got that from some providers who were not reconstructive surgeons. So I didn't know why they cared about what size boobs I wanted. Now, I will say that even though I did stick to my medium boob desire, I did have to pivot a little bit when it came to the type of surgery I was getting. I wanted to get the deep flat procedure when I heard about it. Now, my friends a couple of them told me that I had been living under a rock because I was not aware that they could take fat from some part of your body and create a breast from it. One of my friends had said to me, "Don't you watch the Kardashians?" I think I watched them like a decade ago, but not enough to have known about this surgery. But I was very excited about it. But I also looked at my body, and being both slim and muscular, like fat is actually not something that comes in high supply for me. So I knew that there were limited areas where they could pull from. One of the reconstructive surgeons I talked to had told me that I could probably use my stomach to get enough for one boob. But it turned out that, in fact, when I went to the final surgeon that I ended up going with, she explained to me that because I had not yet had children and wanted to still carry a child, it would be sort of a challenge because my skin had not been stretched there, and it would make it harder for me to do that. So I ended up deciding to go with an implant. And honestly, I was okay with that because having a child is something that's important to me, to at least have the possibility of that. I was okay with having to pivot. And because I didn't even know about the DIEP flap procedure 2 months earlier, it wasn't a huge loss for me. So it also turned out that that helped me to have an easier recovery process too than I would have had if I had done that procedure. And that was what happened. I had my first procedure I had was my mastectomy, and at that point I had a tissue expander put in to prep my skin, and it was in there for about 6 months before I had my surgery, and that was filled with saline. And honestly, getting it filled with saline was just a very important moment because it meant that I could have my medium boob while I waited for the actual surgery to get my implant. And
So you can go on our website and hear the rest of her story. But in the interest of time, I'm going to move on to the last sort of future of where we're headed. Um, you know, the next decade and the next mountain, whatever the new things that we're going to be doing with innovation are already underway. But I don't think they're mainstream everywhere. So things like lymphedema surgery, sensory restoration, and robotic surgery for deep flap reconstruction. I'll touch a little bit on those and sort of where we are. We have a lymphedema program at Hopkins where there are several different procedures that can be done. Some can be done in a delayed fashion. Some are now being done at the time of mastectomy if extensive lymph node resection is involved in order to help prevent lymphedema. You can check us out there. Sensory preservation is something that's become very important, and it's unfortunately it's not a great revision surgery. We don't have that technology yet fully online, but we can do it in order to try to preserve whatever sensory nerves are there at the time of the mastectomy. It requires immediate preservation and sometimes nerve grafting and a coordination between the breast surgeon and the plastic surgeon. But it's something that I advocate for pretty extensively with all of my patients because, I feel like we've moved beyond the stage where we have to say to everybody, yes, you're just going to be numb. And I think we can do better. A lot of people are very obsessed about nipple sensation and erotic function, and I think that that's important for some people. But for some people, they just want to know where their breast is in space. I can't tell you the number of people who've come in with burns from them they were cooking and they didn't realize that they had burned their breasts or heating pads. So I think that it's really important to have that conversation. Unfortunately, nerves grow 1 millimeter a day. So a lot of the studies that we're doing to try to figure out what the techniques are, what's the best way to do it, which nerves we hook up, we'll know in 5 to 10 years because it just takes that long to do the research. And then here's one that I'm most excited about is the use of the robot. Everybody thinks the robot and the laser are magic, and they've been well used in pelvic floor surgery for prostatectomies and for GYN surgery and colorectal surgery. And the area where plastic surgeons are using it the most, where I think it's going to give patients the most benefit, is actually in the pedicle harvest for deep flap. So as it stands now, standard of care is you have to actually open the muscle fascia to dig out the blood vessels that we use to connect to the chest. And that requires an incision that's 10 to 12 centimeters on the fascia. But if the patient has favorable anatomy, we can actually use the robot to do all that dissection from underneath, from the side, and we end up making a 2 to 3 centimeter incision on your fascia. And I think that that's where we need to be thinking. We need to be pushing the envelope and sort of trying to pull everybody in that direction. Now it requires retraining for all of us deep flap surgeons, so it's not fully online everywhere, but I think it's kind of the future. Other things that we're working on more in the lab are things like tissue engineering. I imagine one day we're going to have scaffolding that's going to be like a loofah sponge that we just, put your own fat into, that we can make a breast 3D printing of breasts. We're using 3D printers right now to help create a mold or a shape of the breast that we can then use for the contralateral breasts to help make them more symmetric. There are better implants in R&D. The FDA has just approved a new device here in the US that we don't have access to yet, but there are places that are getting approval in their state. And then off-the-shelf fat. And then this is coming again state by state, depending on the regulations. But some patients who need fat grafting, unfortunately, the people who often need the most of it don't have great fat stores. So we're coming up with ways to do that. So here's a shout out to my team. That's the Bayview team with our PAs. We also have a team up at WellSpan, and these are our folks down at Sibley for those of you who are closer to there. I'd like to thank everybody for joining us, and I'm going to turn it over to the Q&A section right now. Okay, so I'm going to read through some of the questions that have come through the chat. The first one is, are there certain revision procedures that have less post-op complications than others? Or is it dependent on my BMI, breast reconstruction history, etc.? Yeah, I think that that's true. I think that there are some things that have fewer complication rates. Certainly, any revisions to the skin are going to be a little easier to do if you need some skin tightened, if you just need a lift. At that point, the skin, the blood supply to the skin that we worry so much about at the time of the mastectomy has all been matured. Fat grafting is something that's pretty well tolerated, but you can have a fat embolism or a blood clot. So I think these are very, very specific. It also depends on your medical history, whether or not you're prone to clotting. There are people who are prone to clotting disorders. It also depends on other surgeries that you have. We don't want to do liposuction if you've had a hernia repair in your belly, for example. So I think that's some of that's very, very personal. The next question is, will you accept me as a patient if I did my breast reconstruction outside of Hopkins? Absolutely. That is actually the best part about my talk, is that most of those patients had their original surgeries elsewhere. We recognize that we are a tertiary or quaternary, I guess is a better way to describe us, center where we are pushing the envelope on some of these surgeries and coming up with new techniques. And we often get referrals for people from out of state, from other surgeons. I have no problems with that. And I think most surgeons are very happy if their patients ultimately are happy, and they don't really care who gets them there. Next question. You mentioned a patient had to stop smoking to proceed with her surgery. What are other things to keep in mind before someone is cleared for surgery who would not qualify for a revision surgery? I mentioned the stop smoking, and that's a very specific thing. When we're dealing with the skin of reconstructed breasts is very delicate. So I like to think about, there are risk factors that make reconstruction failure higher. Some you can change, or what we call mitigatable risk factors. One is your weight. If we think that you need to lose weight, you can do that. You can quit smoking. You can't really undo radiation. That's another risk factor. You can't undo some of your prior surgeries. So I think you just sort of balance all of those, and your history of clotting disorders. Have you had reactions to certain medications? Those are all things to take into consideration, but I don't think it counts people out. I feel like if you're coming in for revisions and you really are committed to changing your shape, we need to just go full on and remove any barriers or anything that's going to make you higher risk for having a failure and being dissatisfied. The other thing I would point out is anybody who's interested in a deep flap, if you've had a tummy tuck, that will disqualify you. We'd have to look for other ways to bring in tissue from another part of your body, because the tummy tuck is basically the tissue that we would use. Liposuction of the belly is not an absolute contraindication, but it's one that I use. I go slowly with that, because when you do liposuction, you can disrupt those little tiny blood vessels that we need to have. So we would image you and see if those blood vessels are there. Sometimes I do what's called a vascular surgical delay, where we make incisions around the belly, we skinny it down to the blood vessels we think we need, and then we wait and we look to see if the branches that are coming up into the skin and the fat that we need to have alive are alive, or whether or not there's too much scar tissue from the liposuction to make that work. It's not an absolute. Next question. Once you've had a stacked deep flap, with a revision where eventually the fat was lost? Can you do another transfer of the fat? So yes, I think so. I think that, fat likes fat. So if you have tissue that has fat from a stacked deep and you have a donor site that we can harvest again, and do liposuction from and then transfer it into the flap, there is a chance that it will be successful. It's hard. It depends on what the fat grafting was transferred into. So sometimes people have a lot of what we call fat necrosis, where part of the fat just didn't survive and it died and it got very hard. And when we graft into that, that is less successful the first time, but it doesn't mean you won't have more success on subsequent transfers. In fact, when I'm just doing implant-based reconstruction and I'm trying to thicken the skin flap on my very skinny minis who have basically just skin on top of their implant, I tell them that the first job of fat grafting is really just to establish some fat, that then the second round is going to take a whole lot better. When we send the fat in with lipofilling, we harvest it as a slurry, and it is basically concentrated fat, but it doesn't have its own blood supply. So you have to inject it into something that has a matrix with it that can grow a blood supply so the fat can actually grow and it won't die. You can't just squirt it into a space or a pocket, which is why we don't just use the skin, take the skin and just squirt a bunch of fat in there, because we don't have that matrix for it. We're working on that. Technology's in progress, but it doesn't exist yet. And so it's important to have that. So sometimes you can go back in and you can do more fat grafting. Next question. Love that you mentioned examples of research that surgeons are working on. Can you explain nerve grafting? I'm worried about losing breast sensation. So as it stands right now, what we do for nerve grafting is at the time of the mastectomy, and either the breast surgeon does this part and starts it, or we start it, depending on what the team is most comfortable with and the timing, because we often work together, is that the nerves that are used most commonly are nerves that come off of the intercostal bundle underneath the rib. So your nerves that come out to the nipple and to the nipple skin, and the skin around the nipple comes out from underneath the rib, and it comes out through the tissue and it branches and it goes actually into the breast. So what we do is we dissect, or we actually tease that nerve out of the breast. It's very safe. We're not taking breast tissue with it, so that we can get more length. Now the problem is as it gets further out, it gets smaller, so it's not really as helpful. But then what we do is we actually then can dissect it back down to the rib level to get a little bit more length. And sometimes that's not enough length to get all the way out to the skin, because it's got to go out and around whatever implant or device. So it's more useful in smaller breasted women. And then we can use either an off-the-shelf graft, or if we have two nerves that are next to each other and one looks, we can add length to that. We can do a nerve graft, and we basically just sew the nerves together. Now the nerve has to grow from the chest wall, from the intact nerve, into that second nerve, and then grow all the way down the length of the nerve and get out to the skin. So that's sort of how we do it. And I feel like right now we know that this works in some patients, and you can get protective sensation, you can get erotic sensation, you can get various sensation. Not everybody gets the same amount of sensation, though. That's true. And we don't know yet still which nerves are the most important ones to hook up. Is it the second nerve, the third nerve, the fourth nerve, the fifth nerve, all of them, 5 nerves? That is being worked out at some of the larger centers that do very high volume of this. So ask me in 2 to 3 years and I'll be able to tell you a little bit more. But it's something to discuss with your surgeon before your mastectomy, because once a mastectomy happens, those nerve endings, they lose their ability to be grafted at that time. Next question. I recently had an implant added to create volume on my deep flap. While I'm very happy with that outcome, I'm unhappy with my back and stomach where the fat was taken from, particularly just above the scar. I work out regularly, feel like I just can't change that part of my body. Will insurances cover a revision for that? I have dimpling in the back of my upper thighs and my low back. Yes, I would say they probably will. It depends on your policy. Everybody's policy is a little bit different, but it's definitely worth looking into. I've had patients that have gotten some dimpling. I usually take from the thighs because I don't like the back fat. It doesn't give me the kind of fat I want. But I have had, and we just go back in, and what you often have to do actually is transfer a little bit of fat. You can either lipo above or below, and then you transfer a little bit of fat into that dimpled area. Sometimes patients need more surgery. You actually have just a bunch of loose skin, and that skin needs to be removed. But it's something worth exploring. Currently, every policy is a little bit different, but the current recommendations are that any revisions of reconstruction are currently still covered under health insurance policies. So unless any of that changes, in the coming years, this is all covered. So it's worth having that conversation. You can always ask. And then the last question here says, after my first consult with you, what is the typical time frame to get scheduled for surgery? That's a great question. You can ask my scheduler. I can tell when I promise people dates. I would say my surgical scheduling is usually 3 to 4 months out. It depends on what you need. I reserve special slots for my deep flaps because they're all day surgeries, and I don't do them back to back. I'm solidly in my 50s now, and I have to be thoughtful about how preserving my longevity. But yeah. A couple more. Does fat from grafting pose the same risks of recurrence as if you had regular tissue? I don't know if I fully understand the question, but if I think I understand what the question means, what are the risks of fat grafting into an intact breast, somebody who had a lumpectomy and radiation? And I would say that the studies on that are optimistic, that it doesn't necessarily increase the risk of recurrence. We know that fat grafting into a breast that had a mastectomy definitely does not increase the risk of local recurrence. I think we need a little bit longer history for looking into fat grafting into breast tissue itself that's had prior cancer and lumpectomy and radiation. But the early data indicates that it is safe. And so there are a lot of surgeons that do that, that have that in their practice. Next question. My breasts are bluish in color due to the thin skin. Can anything be done for this? Maybe. It depends on whether or not this is something that we can fat graft. The bluish color has a lot to do with the fact that you can see the blood vessels and the capsule itself underlying there. And so you don't have that fatty layer to camouflage that. When I see patients with bluish skin, I often am going to be thinking to myself, can we just thicken that skin with fat? Or can we help support the skin a little bit better by downsizing the implant a little bit as we do that so that we get the same overall volume if that's what the option is? Or do we just say, you know what, the skin is just burnt out and we need to think about using your own tissue? There are some surgical meshes that are off-label. Actually, all surgical mesh in the breast, I should say, is off-label in terms of the FDA, but it's ubiquitously used. That some of them we think are providing a little bit more internal support, which will help take the weight off of the skin. So there are some options there. So it's definitely worth exploring. I wouldn't wait till your implant erodes through your skin. Next question, is the usual solution for animation and deformity with under the muscle to switch to over the muscle? Is there a way to fix that flatness with the incision straight across the nipples removed So for the first question, I think yes. I think if you have animation deformity and you can fat graft to camouflage it, but I don't find that that's as effective as it is for putting the muscle back down and just doing the entire reconstruction on top of the muscle. And a lot of times when people have that incision across the front of the breast, if they have an animation deformity and they have the muscle pulling, like on the patient that I showed you, you'll notice that the skin below the breast is flat as well. And a lot of it has to do with the fact that the edge of the muscle often lines up with where that scar is. So it just exacerbates the problem of that flat front. So if we're able to put the muscle back down so it's not pulling on that skin anymore, you can reshape the skin and either remove a little bit from the sides to make it more round or coned, and then it will reform in the shape of the device when you put a round device in there. Can I bring in goal pictures for aesthetic purposes? Absolutely. Love goal pictures. It gives us a really good conversation, and I can have expectations of what you think you want, and we can talk about whether or not that's realistic. I often, for my second stages, have my patients bring in aspirational photos. For me, it's not as helpful to know the number of the CC implant that's in there if we're doing an implant-based reconstruction, but really to see what the shadows and the shapes and the borders of the breast look like, because I think that aesthetic is really important. And every reconstructive surgeon has a very different aesthetic. There are going to be some plastic surgeons that are going to want to give everybody that really round augmented look. There are going to be some that give you a much more natural look. So I think it's really helpful to have that conversation ahead of time, bring in your aspirational photos. And also, I always tell people to bring a couple of photos of what you don't want, right? So if you really don't want that really augmented high shelf look, bring that in so that I know, because I sit people up with sizers on the table and we look at the photos, and my staff helps me decide. If I'm 50 plus, can I still do a flat closure if I don't want to do implants? Yes, always, anytime. I might recommend a Goldilocks actually, because the flat closure, sometimes if you have your skin and you have a device that's often really, really thin, and I have found some patients get a little bit of tenderness along the rib from having really thin skin there in the front. Okay, I'm getting told it's the last questions. What does follow-up care look like? Will I be seeing you, a physician assistant, or a nurse? That's a great question. I have currently, for most patients, a 1, a 2, sometimes a 3, and a 6-week plan for post-ops. I see everybody that first week, unless I'm out of town or it's something fairly straightforward. My PA has been with me now for 7 years, and she's basically my mini me. And so if you're doing great, I turn you over to her so you don't have to sit in my waiting room. If you read any of the online reviews about me, I'm always overbooked and I'm always running behind, and I don't think that's fair when you've got drains in and things like that. So if there's anything I'm worried about, though, I keep you seeing me until I'm comfortable that we've gotten past that point. And then I usually see people either at the 6 to 12, somewhere in the 6 to 12 week period, and we figure out what your next steps are going to be if we need next steps. But my PA often does that. I don't have a nurse in our practice, just the way Bayview has it set up for me. So it's either me or my PA. And if she has any questions, I'm always around, but she can handle most things.
This will conclude this evening's webinar. We apologize if we were not able to answer all questions. If you would still like to have your question answered, please feel free to email hawkinsseminar@jhmi.edu. We would like to thank Dr. Broderick for presenting, and thank you everyone for joining us today. A recording will be emailed to everyone within the next few days. If you are interested in scheduling an appointment, please call the number on your screen. Thank you.